Okay, so good afternoon or good morning to everyone, and also good morning to the people joining us online. Welcome to the session entitled Internacionalización de la estrategia de implementación MedeA. First, I would like to thank to the organizer, to the INUBE, and to the RIBEF, and also to the medical school for hosting the conference. So after the great presentation by Dr. Adrián Llerena about the MedeA project, that he showed to us all the results and the impact at the national level, we now move to the next step, is the international implementation. So the MedeA project has shown that the pharmacogenetic can be successfully integrated into the routine clinical practice in a public healthcare system. This is very important because MedeA is not just only a local project, it is becoming a model that can be transferred for other countries. The next goal is to take this model beyond Spain and adapt to different healthcare systems, clinical workflow, and patient population. Today, we will hear experience from Portugal, Lithuania, Mexico, India, and Africa. All these initiatives show to us that the MedeA project can be adapted and implemented internationally, supported by a strong collaboration and programs such as EP-PERMET or Marie Curie for Talent for Rural. Of course, implementation of pharmacogenetic in different countries being challenging, such as different in regulation, facility, and access to the testing, and others that we can discuss after. However, the potential benefits are clear: safer treatment, better outcome, and more efficient healthcare through personalizing medicine. The aim of this session is to share this experience and to show how MedeA can be used in other countries. My name is Carmen Mata. I'm the coordinator in the pharmacogenetic and personalizing medicine in the University Hospital of Badajoz. And it's my pleasure to moderate this session together with Dr. Joana Marquez from Rice Health and the Faculty of Medicine, University of Oporto, Portugal. Dr. Marquez is a principal investigator working in genetic and personalizing medicine. Her research focusing on epigenetic and their role in human disease. So the presentation will run for 10 to 12 minutes, and we are running out of the time. So if it's okay for you, we can have the round of the question in the final of the session. So let's start with our first speaker. The first speaker is Dr. María Luis Cardoso. Dr. Cardoso is a pharmacist genetic at the National Institute of Health, Dr. Ricardo Jorge, in Lisbon, Portugal. She has extensive expertise in pharmacogenomics and precision medicine, and she is actively involved in major European initiatives such as Beyond 1 Million Genome Project or IC-PERMET. In this context of this session, she will present the PGX Bridge project, a joint EP-PERMET twinning proposal between Portugal and Spain. This initiative aims to implement pharmacogenetics in Portugal by transferring and adapting the MedeA clinical model developed in Extremadura. Dr. Cardoso is unfortunately unable to join us in person today, but she has kindly shared a recorded presentation. So we will now to play her talk.
Good morning. First of all, I would like to thank Professor Adrián Llerena and Carmen Mata for the kind invitation to participate once again on the RIBEF meeting. It is a real pleasure to see this network grow over 2 decades, and seeing more and more people engage with pharmacogenomics and pharmacogenetics across countries and disciplines is encouraging. It is a sign that we are moving in the right direction. 2 years ago, I had the opportunity to participate in RIBEF meeting in Badajoz, and it was an opportunity that marked the beginning of a closer collaboration between the National Institute of Health, Dr. Ricardo Jorge from Lisbon, Portugal, and INUB from the University of Badajoz. But is it important to say that this collaboration did not start from zero. Colleagues from Évora, Coimbra, Covilhã had already built bridges with Extremadura before us. So this collaboration grew from many hands across many regions over many years, and we have a long collaboration across the Iberian space. And what is particularly interesting in this cross-border work is the process and the progress of the collaboration. We know the science, we know the pharmacogenes, the metabolizer phenotypes, quality control frameworks. The real question for us was something much more complex. How does pharmacogenomics become routine clinical practice? How do we move from scientific evidence to real implementation in healthcare systems? And how did initiatives such as MedeA manage to overcome implementation barriers and become a real reference for all of us? It was with these questions in mind that our collaboration with INUBE got stronger. We exchanged more than workflows and perspectives. We want to make it to work in practice together. It becomes clear that this was not only about transferring the model from one system to another, because despite similarities, we also have differences. The goal was not to replicate MedeA, but to understand how the ecosystem was built and sustained. And it has been strongly shaped by the vision of Adrian and his team. We had some dialogues, sometimes structured exchanges, sometimes informal conversations to understand how the model could be adapted to be integrated in routine care within public health systems, including the Portuguese national health system, hospitals, and also in primary care in a realistic and sustainable way. Some years ago, I also had the opportunity to interview Adrian in the context of a project, the Prophet project. At that time, we discussed his vision of pharmacogenomics as a tool, not only for improving efficacy and safety, but also to prevent severe adverse outcomes, including avoidable hospitalization and other serious clinical events. We also discussed the challenge of implementation in primary care, prevent suicidal, and how some of his ideas were already being translated in practice in his region. So, INUBE has already many years of experience in operation pharmacogenomic workflows. They have a structured clinical interpretation and clear actionable reporting already applied in routine care. They provided scalable training programs for health professionals together with a strong governance and quality assurance frameworks. This combination triad of clinical integration, training, and governance is what makes the model operational and sustainable. In Portugal, we are currently in a different phase. The National Strategy for Genomic Medicine has recently gone through public consultation. It reflects a growing national commitment to integrate genomic medicine in healthcare delivery. Although pharmacogenomics is not defined as a separate program, it is clearly present within the broader strategy discussions, including stakeholder workshops and expert consultations. In this context, the National Institute of Health plays a central role. It provides scientific leadership in genomics and public health, reporting directly to the Ministry of Health, and it is fully embedded within the Portuguese National Health Service, working closely with hospitals and primary care across the country. So, the National Institute of Health has a unique range of expertise from bench to policy, which positions it to embed pharmacogenomics in the national health system, and in this process we are actively looking for the experience of our neighbours. There is also another important dimension that reinforces this collaboration. Portugal and Spain share a very close background at the population level. This proximity is not only geographic but also biological, and it has implications, for example, for allele frequencies, variant distribution, and clinical interpretation in pharmacogenomics. In this sense, collaboration across borders is not only practical, it is scientifically meaningful. And this collaboration opens the door to a cross-border framework for sharing real-world evidence between both countries. So, what we see today is a growing ecosystem of collaboration, one that is based on shared experience and continuous exchange. We will continue working together. We will continue learning together. And we will continue building a common understanding of implementation. Finally, I would like to end by congratulating RIBEF on its 20th anniversary. It is not easy to maintain a network active and relevant for 2 decades, but the fact that RIBEF continues to grow, bringing more people into this conversation is a clear sign of its vitality. So thank you, obrigado y muchas gracias.
No, thank you, Doctora María Luis Cardoso. So the next speaker is Dr. Batis Tatarunas. Dr. Tatarunas is a researcher at Lithuania University of Health Science with a strong expertise in cardiovascular pharmacogenomics and clinical research. His work focuses on translating pharmacogenomics into the routine clinical practice. He will present the Cardiopharmacogenetics Twin Project, a recently funded EP-Permet twinning initiative developed in collaboration with our group. This project aims to implement pharmacogenomics in cardiovascular care in Lithuania by transferring and adapting the MedeA clinical model. It is a really important step in the international recognition and transferability of the MedeA model. So, Dr. Tatarunas, the floor is yours.
Thank you. So I will focus on how MedeA pharmacogenomics implementation strategy, which was developed and operationalized in Spain, can be internationalized through implementation in Lithuania. So it's not a conventional project. It's not a research project, and it's an implementation project. And the donor site is Extremadura Health Service in Ube, and also the MedeA program. It brings an already operational pharmacogenomics enabled prescribing model, and LSMU, it means Lithuanian University of Health Sciences, Kaunas Hospital. It brings a strong clinical and academic capacity in pharmacogenomics research. So internationalization here does not mean only dissemination, publication preparation, or lectures. It means transferring of working implementation strategy from one healthcare system to another, and showing its core components can be adapted without losing a clinical value, quality, and safety. And Spain has a mature donor model, MedeA. It combines pharmacogenomics interpretation, and LSMU Kaunas Hospital, together with LSMU University. It is the adaptation site. And why? Because LSMU has a strong research capacity, but it hasn't structure for pharmacogenomics implementation into clinical practice. So why cardiology and why pharmacogenomics? Cardiovascular medicine is a strong use case for pharmacogenomics because treatment response is highly variable in patients using cardiovascular drugs, and many of these drugs are still prescribed using a population-based model. It means one drug and one dosage fits all, but it's not right way. And pharmacogenomics can identify clinically relevant patient subgroups, and it allows to choose the right drug and the right dosage before prescription. So a familiar example could be clopidogrel, a drug which which is metabolized through to C19, and loss of function variants can reduce clopidogrel activation in patients having polymorphism. So selecting of these patients will help to prevent adverse drug reactions and drug ineffectivity. So MedeA should be understood not as a clinical operating model for pharmacogenomics enable prescribing, not only as a database or a CDSS, clinical decision support system, and it is package of components that work together. And first, evidence and roles. Interpretation is aligned with recognized pharmacogenomics standards, such as CPIC, Clinical Pharmacogenomics Implementation Consortium, DPWG, or Dutch Pharmacogenomics Working Group papers. Second, data and reporting. Genomic clinical medication information are translated into clinician-oriented recommendation. A third, the workflow clinical trigger leads to pharmacogenomics data, interpretation, recommendation, and documentation. And fourth, governance, rules, accountability, quality assurance, approval, version control, and escalation of complex cases. And fifth, last, training. Clinicians, pharmacists, geneticists, laboratory staff, and data colleagues must understand their roles. This is why MedeA can be internationalized. Lithuania is a strong candidate for MedeA internationalization because the starting point is not zero, as I told already. Lasimų Kaunas Hospital and University, we have environment which already have expertise in pharmacogenomics, in cardiovascular medicine, laboratory, diagnostics, clinical pharmacology, and this creates a strong basis for absorbing and adapting this model. And at the same time, there is a clear implementation gap. Pharmacogenomics is available and reimbursed in selected areas such as psychiatry, but it's not yet routinely embedded in cardiovascular prescribing pathways. And this gap is operational. There is no standardized cardiovascular pharmacogenomics SOAPs documents, no routine report model, no formal governance structure, and no stable multidisciplinary case discussion format. So this makes the project well suited to twinning, and this is because we won this project. A PPERMET twinning project is a vehicle for internationalizing MedeA strategy. So it gives us a structured 12-month implementation strategy to adapt, to embed a major personalized medicine implementation model. And the first step is transfer. It means training, job shadowing, MedeA workflow review, pharmacogenomics interpretation principles, reporting templates, governance examples. The second step is adaptation. Lithuania defines the first clinical scope, local triggers, data governance, documents like SOAPs. We will adapt REDCap, CDSS, And the third step is embedding. It means end-to-end testing, structured early use, case board discussions, clinical training, process metrics, sustainability roadmap. And it is important to be precise that this is not a research project, it's not a clinical project, it's implementation project. And what will be transferred? A common mistake in international implementation is to copy the donor implementation model exactly, and that is not the goal here. The stronger approach is to separate the standardized core from the local configuration, and from MedeA and Spain, we will transfer pharmacogenomics interpretation principles, gene drug decision logic, roadmap, reporting structure, SOAP templates, governance, quality assurance principles. And at our hospital, also university, these elements will be adapted locally. So it means we'll select the first cardiology unit, clinical scope. We will define the local clinical trigger. We will assign the rules through RACA. We will align the report with Lithuanian documentation, and we will involve data protection and ethics contacts. So the project is short and milestone driven, with a practical start, which was already on June 8, 2026. The first months must be focused, and the first internal decision is scope freeze by June 30. It means that we will have one cardiology unit, one or two priority gene drug pairs, the core team, and we'll define donor workshop dates. Deliverable one is the interim report, and it will be on 16th of October 2026. And it should show that the foundation is in place. So it means governance, stakeholder engagement, gap analysis, donor workshops or milestone 1 outputs, draft workflows, documentation like SOAPs. Deliverable 2, it means final activity report is due on 16 April of 2027, because the project is short, and it should show that final SOAPs, governance, validated report, model training, case discussions, these things are working. And the last date to present our results is 6th May of 2027. For the first implementation phase, we should not try to implement pharmacogenomics across all cardiology or across all units in the hospital. And the safest approach is one cardiology unit, one or two priority gene track pairs, for example, clopidogrel, statins, metoprolol, like beta blockers and warfarin. And the core implementation infrastructure is governance, SOAPs, CDSS REDCap report model, and these may sound administrative, but what turns pharmacogenomics from expert knowledge into a sustainable clinical process. And the value of Lithuanian implementation is not limited to one hospital. If MedeA works in Spain and it can also be adapted in Lithuania, it becomes much more credible as a transferable European model. And as you know, Spain and Lithuania differ in workflows, digital maturity, reimbursement pathways, organizational structures. So successful transfer would demonstrate robustness of this project and of this model. And there are three internationalization outputs. First, a transferable toolkit, SOAPs, templates. Second, a Lithuanian reference model. It means a first cardiology pathway, first working pathway. Trained multidisciplinary team, institutional roadmap, early use lessons, local adaptation decisions, and continuity plan. And third, European scale-up potential. It means transfer to other Lithuanian hospitals, extension beyond cardiology, and future cross-border projects. So by May 2027, the expected outcome will be a functioning, standardized, and scalable pharmacogenomics implementation model in cardiology at LSMU Kaunas Hospital. And this means genetic information will be used in structured way to support individualized medication prescribing. Thank you for your attention. And this is a picture from Lithuania's biggest river in Lithuania, Nemunas.
So, good morning, everyone. We will proceed with the talks. Next, it is my pleasure to introduce Dr. Gustavo Altamirano and Dr. Miguel Fonseca Sanchez. Dr. Gustavo and Dr. Miguel are clinicians and researchers at the Hospital General de Mexico, Dr. Eduardo Laciaga. Their work focuses on advancing precision medicine and pharmacogenetics in clinical practice. They are unfortunately unable to join us in person today, but they have kindly shared a recorded presentation that we will see. In the context of this session on the internationalization of the MedeA strategy, they will present their ongoing work to transfer and adapt the MedeA model to Mexico as part of a proposal currently under development.
Muy buenos días desde la Ciudad de México, desde el Hospital General de México, Eduardo Laciaga. Los saluda el doctor Gustavo Acosta Altamirano, el director de investigación de este prestigiado hospital. Muchas gracias al doctor Adrián Llerena por permitirnos participar en esta jornada de implementación de la farmacogenética y de la medicina personalizada en Iberoamérica. Es un honor para nosotros como Hospital General. Nosotros estamos ubicados al sur de la Ciudad de México. Es un hospital general que atiende a la población más vulnerable de nuestro país y en el cual tiene alrededor de 100 camas censables. Se considera que es un hospital el más grande de la República Mexicana, con todos los servicios que conlleva un hospital general. Medicina interna, ginecobstetricia, la parte de pediatría y una gran actividad quirúrgica. Como ustedes están observando, pues nosotros tenemos mucho interés en participar en el proyecto MedeA, que ha sido internacionalizado por el doctor Llerena, y agradecemos su apertura para poder colaborar en este gran programa de farmacogenética. En este Hospital General de México, nosotros formamos parte de la Comisión Coordinadora de los Hospitales Regionales de Hospitales e Institutos de la República Mexicana, y pues para esto me acompaña el doctor Miguel Ángel Fonseca, quien es el jefe de los servicios de registro de protocolos de investigación de la misma dirección de investigación, que nosotros estamos en comunicación permanente también con la dirección médica, con la dirección administrativa y formamos un equipo de trabajo que tenemos a su bien tener este proyecto de gran importancia para el hospital y que seguramente nos comprometemos para obtener unos mejores resultados en beneficio de nuestros pacientes. Doctor Fonseca.
Gracias a todos por esta oportunidad de poder participar en este proyecto tan grande. Agradecemos nuevamente al doctor Llerenas el impulso que nos dan a través de la organización de MedeA. Finalmente, lo que queremos resaltar es que nuestro proyecto lo que quiere hacer es implementar toda la información que ustedes ya han generado, y lo que queremos hacer es poder utilizarla como un marco de referencia para poder realizarla e implementarla en nuestro hospital. Este proyecto lo que queremos hacer es implementarlo en varios niveles. Primero, en primer lugar, es que toda la información que oportunamente ustedes nos están compartiendo nos sirva para poder hacer una validación inicial de este proyecto. Es lo primero que queremos realizar a través de esta importante colaboración. Y en segundo lugar, una vez que tengamos esta validación, lo que queremos realizar es la búsqueda de nuevos marcadores para poder diseñar paneles personalizados a la población mexicana. La población mexicana que, como ustedes lo conocen, o si no es así, se los comento, por parte de nuestra historia tenemos una variabilidad genética muy importante. Y estos paneles que han sido diseñados y que ya han sido probados en poblaciones europeas corresponden a este tipo de población. Ahora lo que queremos hacer y lograr gracias a su apoyo es hacer esta implementación en nuestro país, ocupando y analizando las variabilidades genéticas que existen en nuestra población. Y el tercer eslabón que queremos hacer con este proyecto es finalmente que nos sirva como un pionero para que nuestro país sea un referente en ese sentido. El Hospital General es una de las instituciones más fuertes, tanto a nivel hospitalario como a nivel de investigación, y va a ser punta de lanza junto con ustedes para poder llevar este tipo de tecnologías al resto de nuestro país. Si logramos hacer que esta implementación sea útil y sea implementada en el hospital, va a tener varios beneficios. En primer lugar, por ejemplo, vamos a poder tener una medicina personalizada, que es lo que queremos. Ustedes como especialistas en farmacogenética saben que para poder tener un efecto justo o más eficiente de los medicamentos, pues podemos hacer estos medicamentos a la medida. De esta manera nosotros sabríamos, por ejemplo, qué paciente va a responder de manera más eficiente, qué paciente no va a responder o qué paciente va a poder tener complicaciones. Con esto tenemos dos beneficios. En primer lugar, vamos a ahorrar costos porque vamos a poder dirigir medicamentos de manera más eficiente para saber quiénes son los que están respondiendo a ese medicamento. Y en segundo lugar, pues lo que vamos a ver vamos a lograr evitar son complicaciones. Y justamente para hablarles de las complicaciones que se nos presentan algunos medicamentos, pues está con nosotros el doctor Amancio, que es el que nos va a poder explicar justamente todas las complicaciones que tenemos por estos medicamentos. Doctor Amancio, si nos gusta explicar.
Efectivamente, doctor, vamos a ver las actividades de farmacovigilancia que se utilizan que se realizan en nuestro hospital. Desde hace 20 años vamos a presentar los resultados de los principales medicamentos y grupos farmacológicos que producen reacciones adversas. En esta primera imagen vemos que desde mayo del 2006 hasta abril del 2026 hemos tenido 4.797 pacientes que han presentado reacciones adversas para dar un total de 10.310 reacciones. Básicamente nosotros realizamos a las actividades de farmacovigilancia acudiendo a la cama de nuestro paciente. Se hace una revisión del expediente, se platica con los médicos y las enfermeras si han presentado algunos pacientes reacciones adversas y de ahí se realiza y se lleva a cabo la notificación. Con respecto al sexo, pues básicamente el grupo femenino es el que más se ve afectado. Esto está íntimamente relacionado con los informes que se reportan en diferentes países. Las mujeres desafortunadamente presentan un mayor número de reacciones adversas, básicamente por su farmacocinética y en algunos aspectos incluso por aspectos farmacodinámicos. Con respecto a la edad, en nuestro hospital general tenemos dos modas de 40 a 50 y de 51 a 60. Afortunadamente tenemos todo el espectro de edad, va desde niños de meses, de días, 4 días, hasta un paciente que tiene 96 años de edad. Con respecto al número de reacciones adversas, tenemos 1.972 pacientes presentaron una reacción adversa, 1.182 dos reacciones adversas, 925 y así sucesivamente. Y esta es de ahí la suma que nos da 10.310 reacciones adversas en este periodo de 20 años. Ahora bien, ¿cuáles son los grupos farmacológicos que mayor número de reacciones adversas presentan? Bueno, aquí lo dividimos en 3 grupos. Por grupo de medicamentos tenemos 47 medicamentos antineoplásicos, 73 medicamentos antimicrobianos, 16 medios de contraste y 60 tipos de analgésicos. Algunos de ellos incluso son combinaciones, tramadol con paracetamol, con ketorolaco, etcétera. Si nos vamos desde el punto de vista de nuestros pacientes, de esos 4.797, bueno, el grupo que mayor número de reacciones adversas tiene es el grupo de antineoplásicos con un 28.4%, seguido de antimicrobianos con un 21%, medios de contraste 12% y analgésicos 10.5%. Y si nos vamos ya al grupo de reacciones adversas, pues bueno, sin lugar a duda no es diferente a lo que se reporta. Antineoplásicos 37.7%, antimicrobianos 19.1%, medios de contraste 9% y analgésicos 9.6%. Realmente estos son los 4 grupos farmacológicos que presentan un mayor número de reacciones adversas en nuestra población. Ahora bien, ¿cuáles son los medicamentos que presentan mayor número de reacciones? Bueno, aquí está en primer lugar la fluoresceína sódica, que se utiliza para realizar la fluorangiografía para la evaluación de la retina. Ella ocupa 6.5 desde el punto de vista de pacientes o 5.9. El segundo son el grupo de antineoplásicos, paclitaxel, 5-fluoruracilo, tenemos etopósido, oxaliplatino, carboplatino, por mencionar algunos, hasta llegar a ifosfamida, que tiene más de 46 reacciones adversas en nuestros pacientes. Desde el segundo grupo lo tenemos representado por los antimicrobianos, ciprofloxacino, ceftriaxona, vancomicina, por mencionar algunos, y en tercer lugar tenemos a los medios de contraste. Ahí sí hay un buen grupo de medios de contraste, iobromida, iopamidol, iovitridol, por mencionar algunos. Ahora, ¿cuáles son las reacciones adversas que se presentan en nuestra población? Bueno, sin lugar a dudas, las gastrointestinales son las que ocupan un mayor número: náuseas, vómito, diarrea, por mencionar algunas. El segundo serían cefalea, las que afectan al sistema nervioso central, cefalea, mareo, ocurren parestesias localizadas. Cuando hablamos de parestesias, básicamente está afectando una sola región de nuestro organismo. Si mencionamos generalizadas, está afectando a 2 o más regiones de nuestro cuerpo. En tercer lugar tenemos, la disnea, que tiene que ver con reacciones alérgicas y las que afectan a nivel de la piel, erupción papular localizada, eritema generalizado, prurito generalizado, erupción maculopapular, por mencionar algunas. Y bueno, por ser un hospital de segundo o tercer nivel, pues la vía que más responsable de producir estas reacciones en un 73% es la vía intravenosa, pero tenemos un 21% que se presentan por la vía oral. Realmente es variadito. Y finalmente vamos a hacer hacia los medicamentos oncológicos. Estos son los 10 medicamentos oncológicos que presentan un mayor número de reacciones adversas en estos 20 años de farmacovigilancia. Paclitaxel con un 19%, 5-fluoruracilo un 19.7%, cisplatino, etopósido, oxaliplatino, carboplatino, doxorubicina, ifosfamida, metotrexate y el asparaginasa. Aquí vale la pena mencionar que en el año pasado tuvimos 5 casos con el asparaginasa de pancreatitis. Con respecto al tipo de a las reacciones adversas, bueno, paclitaxel ocupa el 27, 5-fluorouracilo 23 y afortunadamente menos del 10% el resto de los medicamentos oncológicos. Muchísimas gracias.
La creación del laboratorio de farmacogenómica no es solamente una innovación tecnológica. Realmente es una innovación social y es la manera en cómo el Hospital General de México demuestra que es el estandarte para llevar esta medicina de innovación a la población en general. Esto nos convierte en este referente que nosotros queremos ser, brindando atención de primer nivel que solamente se puede dar en sectores públicos, sectores privados. Ahora, a través de nuestra institución, lo haremos a toda la población en general. Quiero dejar en claro que este esfuerzo es parte de toda la comunidad del Hospital General de México, desde investigadores, clínicos, la Dirección de Investigación y nuestras autoridades hospitalarias a las cuales también les damos agradecimiento. Y también queremos darle gracias a ustedes porque sin la participación internacional de los líderes del proyecto MedeA no podríamos estar logrando a cabo este proyecto. De esta manera, doy por finalizada nuestra participación y a nombre de toda la institución del Hospital General de México y de sus directivos, les damos las gracias.
Hospital General, pilar de la salud en México.
Okay, thank you. Without further delay, let's move to the next talk. It is my pleasure to introduce Dr. Levin Thomas. He's a postdoctoral researcher at the Pharmacogenomics and Personalized Medicine Unit at UNU in Spain. He is a researcher specializing in pharmacogenomics, pharmacokinetics, and clinical pharmacy. His work is driven by a commitment to understanding how genetic variability influences drug response and to advance personalized medicine strategies for improved patient care. He has recently applied for a Talent for Rural Areas postdoctoral fellowship with the aim of implementing pharmacogenetics in southern India, following and adapting the MedeA model. Dr. Levin was unfortunately unable to join us, but he has kindly shared his presentation. He will now play his talk entitled Adapting the MedeA Clinical PGX Model as a Transferable Framework for India.
Good morning, everyone. It's a great pleasure to have the opportunity to present on the initiative of adapting the MedeA clinical pharmacogenomic model as a transferable framework for the Indian healthcare setting. I am Levin Thomas, visiting postdoctoral researcher in Professor Dr. Adrian's research group at Personalized Medicine and Mental Health Unit in Inube. Pharmacogenomic has the potential to transform healthcare by enabling safer and more effective medication use through individualized therapy. However, one of the greatest challenges is successfully integrating it into routine clinical practice in a way that is sustainable, equitable, and adaptable to different healthcare settings. And the MedeA pharmacogenomic program in Extremadura, Spain has successfully integrated pharmacogenomic testing into routine healthcare through a multidisciplinary collaboration. A central vision of this work is to build upon the experience gained through the MedeA pharmacogenomic program in Extremadura and explore how its successful real-world implementation principles can be translated into the healthcare context of Kerala, India. The MedeA pharmacogenomic program provides a valuable real-world implementation platform showing how pharmacogenomics can be embedded within the healthcare systems through multidisciplinary collaboration, clinical decision support, and workforce development. Our goal is to transfer the clinical pharmacogenomic implementation experience of the MedeA program in Extremadura to Kerala, India, and ultimately develop a scalable framework for precision medicine across the country. Kerala is a small state located on the southwestern coast of India and has been long recognized for its remarkable achievements in public health and healthcare delivery. I would like to emphasize on the implementation framework transfer. The objective is not to transfer a fixed pharmacogenomic gene panel or to simply replicate the Extremadura MedeA model. Instead, the aim is to transfer the practical knowledge and the implementation strategies that have enabled the integration of pharmacogenomics into routine healthcare. The MedeA program provides several important components that can be transferred. First is the implementation science, which helps to translate the scientific discoveries to routine clinical practice. Second is the education and training, ensuring the healthcare professionals have knowledge and confidence to use the pharmacogenomics effectively. Third is the integration of the electronic health records and the clinical decision support systems, allowing pharmacogenomic information to be available to the point of prescribing. Fourth is a stakeholder engagement, bringing together clinicians, pharmacists, researchers, policymakers, and patients to support implementation. Finally, the framework emphasizes cost-effective and scalable approaches that can be expanded to local healthcare needs and available resources. Another important aspect of the MedeA program is the experience gained through the real-world clinical pharmacogenomics. This includes integrating pharmacogenomics into primary care, developing clinical decision support tools, and real-world evidence, and building capacity through education and multidisciplinary collaboration. Importantly, the experience gained from the rural healthcare settings in Extremadura provides valuable insights that may be relevant for Kerala and other parts of India. However, successful transfer requires adaptation rather than direct replication. The framework must be tailored to local disease priorities, prescribing patterns, context-adapted pharmacogenomic panels, and the need for affordable precision medicine. The conceptual idea for this initiative has been derived from the Talent for Rural Science Research Proposal Development. Having discussed the potential transfer of the MedeA implementation framework, the next question is, why India? India represents one of the most exciting opportunities globally for the development of clinical pharmacogenomics. The first reason is its unparalleled genetic diversity, with a population exceeding 1.4 billion people and more than 2,000 distinct ethnic groups. India is one of the world's most genetically heterogeneous population. This diversity contributes to substantial inter-individual and interpopulation variability in drug metabolism, therapeutic response, and susceptibility to adverse drug reactions. Furthermore, millions of genetic variants remains underrepresented or absent from existing global reference databases, highlighting the need for population-specific pharmacogenomic evidence. The second major factor is a high burden of pharmacogenomically actionable diseases. India faces a dual burden of communicable and non-communicable diseases, many of which involve medications with established pharmacogenomic associations. These include cardiovascular diseases, cancer, mental health disorders, infectious diseases, and pain management. Optimizing therapy for these conditions through pharmacogenomics has the potential to improve the treatment efficacy while reducing the adverse drug reactions and unnecessary healthcare cost. The third reason is that India is entering an era of emerging opportunities for precision medicine. National digital health initiatives are strengthening the healthcare infrastructure and facilitating the integration of electronic health data, as currently most of the healthcare data is fragmented. At the same time, genomic research capacity continues to expand, precision medicine initiatives are gaining momentum, and advances in artificial intelligence and healthcare analytics are creating new possibilities for data-driven clinical decision making. While India offers enormous potential for clinical pharmacogenomics, successful implementation requires an appropriate starting point. This naturally raises a question: why is Kerala an ideal pilot region for scalable pharmacogenomic medicine? Kerala consistently ranks among India's top performers in healthcare, with excellent health outcomes, a strong primary care and referral network, and has the country's highest literacy rate, all of which facilitate healthcare innovation and early patient engagement. At the same time, Kerala faces a growing burden of chronic diseases and polypharmacy, where pharmacogenomics has significant potential to improve the medication safety and effectiveness. These strengths provide a solid foundation for generating real-world pharmacogenomic evidence, developing clinical decision support systems and practice guidelines, training the healthcare workforce, and evaluating both clinical and economic outcomes. Ultimately, a successful implementation in Kerala provides a scalable and evidence-based model for equitable precision medicine across India, leading to better clinical decisions, improved patient outcomes, fewer adverse drug reactions, and more cost-effective healthcare. Having identified Kerala as an ideal pilot region, the next challenge is determining how the MedeA framework can be adapted to India's diverse healthcare settings and local disease priorities. India has a heterogeneous healthcare system with important differences between public and private sectors and between the rural and urban settings. Therefore, we propose a population-specific implementation strategy while maintaining one common framework. A substantial proportion of the healthcare delivery occurs through the private sector in India. In the government rural healthcare, the priority is on the essential care for the last mile. Here, the pharmacogenomic implementation should focus on common infectious and chronic diseases such as tuberculosis, hypertension, diabetes, HIV, malaria, and cardiovascular diseases. An essential pharmacogenomic panel containing high-impact genes would maximize the clinical benefit while maintaining cost effectiveness. Government tertiary care hospitals manage more complex diseases and have a greater specialist expertise and laboratory infrastructure. Consequently, a broader pharmacogenomic panel can be implemented to support conditions such as cancer, chronic kidney disease, organ transplantation, neurological diseases, and specialized infectious diseases. In the private sector, implementation strategies should also reflect the healthcare needs. Private, rural, and semi-urban hospitals predominantly manage non-communicable diseases and would benefit from an intermediate pharmacogenomic panel that balances affordability with clinical utility for conditions such as dyslipidemia, cardiovascular disease, mental health disorders, and respiratory illness. In contrast, the private urban tertiary hospitals are well suited for a comprehensive precision medicine programs. These settings can support larger pharmacogenomic panels covering oncology, transplantation, rare diseases, advanced cardiovascular care, psychiatry, neurology, and other specialized therapeutic areas. The most important point is that different healthcare settings have different priorities, but they can all operate within the same implementation framework of the MedeA. The same pharmacogenomic may have different levels of priority across the healthcare settings. For instance, the N-acetyl transferase 2 or the NAT2 may be a high priority biomarker for tuberculosis programs in government hospitals, whereas the DYPD or the CYP3A5 may assume greater importance in specialized tertiary care. This illustrates the fundamental principle of our approach, implementing the right pharmacogene for the right disease in the right healthcare setting. The underlying concept is to transfer the implementation experience gained through the MedeA program into the Indian healthcare system. Rather than transferring a fixed pharmacogenomic panel, we retain the core implementation principles while adapting gene selection and clinical priorities to the disease burden, prescribing patterns, healthcare infrastructure, and resource availability of each healthcare setting. Rather than attending large-scale implementation from the outset, we propose a phased roadmap for the sustainable integration of the clinical pharmacogenomics in India. The first phase focuses on building the foundation. This would involve pilot implementation in 1 or 2 rural private hospitals in Kochi, Kerala, using a core pharmacogenomic panel targeting high-impact medication and priority diseases. At this stage, the emphasis is on establishing the clinical decision support systems, training clinicians and pharmacists, and collecting baseline clinical and implementation data to define key performance indicators. Once the feasibility and the clinical utility have been demonstrated, the second phase aims to expand and integrate the pharmacogenomics into routine healthcare delivery. This includes extending the services to additional hospitals, strengthening the primary care integration to reach the last mile of the healthcare delivery, linking the pharmacogenomic data with electronic medical records, and generating real-world evidence on clinical outcomes, adverse drug reactions, medication adherence, and cost effectiveness. The third phase focuses on consolidation and standardization. The goal is to establish a Kerala pharmacogenomic network connecting hospitals, clinics, and laboratories, which develops evidence-based population-specific guidelines, statewide clinical decision support platforms, advanced workforce training programs, and sustainable reimbursement and policy frameworks. Finally, the long-term vision extends beyond Kerala. The objective is to develop a scalable model for India where an equitable precision medicines become accessible across diverse healthcare settings. Such a model has the potential to improve therapeutic outcomes, reduce adverse drug reactions, optimize healthcare costs, strengthen research and innovation, and foster national and international collaboration. Importantly, this roadmap is simply not about introducing genetic testing. It is about building a sustainable precision medicine ecosystem that gradually evolves from local pilot projects into a national scalable implementation framework, with Kerala serving as a foundation for future clinical pharmacogenomic initiatives across India. I would like to thank all of you for your kind attention, and I would be happy to take any comments or questions. I would like to express my sincere gratitude to Professor Dr. Adrian for providing me with the opportunity to work within the MedeA program and for his invaluable mentorship and support. I would also extend my thanks to my colleagues at the Personalized Medicine and Mental Health Unit for fostering an outstanding research environment. Thank you.
Okay, thank you. Now let's move to the final talk. It is my pleasure to introduce Dr. José Gil. Dr. José Gil is a principal investigator at the Global Health and Tropical Medicine Unit at the Instituto de Higiene e Medicina Tropical, da Universidade Nova de Lisboa, in Portugal. He is also an associate professor in molecular pharmacology and has extensive experience in pharmacogenetics and global health, particularly in African populations. In this session on the internationalization of the MedeA strategy, he will provide an African perspective on implementing pharmacogenetics at scale. He will present his talk entitled An African Perspective, Actionable Pharmacogenetics in Large-Scale Malaria Chemoprevention. Thank you, Dr. José. The floor is yours.
Thank you very much. Well, now it's live for once. And thank you for being here. It's always tough to be the last one and still grabbing a bit of your attention. This is a more like focused, say, possibility of application of pharmacogenetics and the spirit of the MedeA project in Africa, which has challenges of its own. I'm going to focus on seasonal malaria chemoprevention. It's a very important WHO supported strategy for the control of malaria in Africa at large scale. And I'm sorry that the title became different this morning. Anyway, we start here. I'm using this also to follow myself. This person is called Aminatou. We are in the southern Mali, an area of seasonal malaria. It's very, very tough during about 4 months of the year, and then it calms down. Aminatou means in the local language trustworthy. And that's a good name because what she's doing is she's preparing the drugs with sulfadoxine, pyrimethamine, and amodiaquine to give to kids, because that's what seasonal malaria chemotherapy is all about. This strategy is focused in 2 large regions in Africa, in the Sahel and in the south, in that belt of the Namibia to Mozambique regions. The idea is relatively simple. Malaria happens 4 months. It's tough. And for small kids that did not develop natural immunity yet, it is very important to try to protect them. So the point is, just before the the season, the kids, when I say kids, it's children under 5-year-old, they get one full treatment of sulfadoxine permethamine and imodiaquine, 3 days, but only the first one is supervised. When followed up, this strategy has an enormous impact. It has been a success for WHO. In full compliance, it decreases 70 to 80% the number of malaria cases during those 4 months. That means decreasing about 10 million cases, and that means 60,000 lives, which are saved. But it has a problem, compliance. Now, this is, as I said, it's only the first dose is supervised, and this is in 3 days. It's 3 doses every month for 4 months, and involves amodiaquine, a great drug by itself. But amodiaquine has a problem. It's associated with very frequent, mild, but very annoying adverse events. But amodiaquine has another thing, which is quite interesting. It is fully and uniquely metabolized by CYP2C8. So that's the first thing which is good, because we can only comply with one enzyme. On top, CYP2C8 is a bit of a strange P450. It's not polymorphic. It has 1 or 2 SNPs. There's one, star 3, in Europe, comes from the Neanderthal, in fact, and there's the star 2 in Africa. Both are minor alleles, but with very, say, robust frequency there. So, continuing. As I said, the use of amodiaquine is associated with adverse events. They are not very serious, but as I said, they are really annoying. It's belly pain, vomiting, etc. And this decreases the compliance on long-term regimens, like seasonal malaria chemotherapy. And actually we realized, us and the group in Yale, that in 2 completely distinct areas of Africa, in Burkina Faso in West Africa, and in Zanzibar on the other side, and Africa is enormously diverse human-wise, we realized that the carriers of the star 2 allele have significantly more adverse events, and they tend not to take all the dosing. So with this in mind, knowing that CYP2C8 has an influence, most likely a direct influence in the compliance, how can we somehow improve this? Just for reinforcing the point, we have made a very large study a long time ago, 5-7 years ago, on repeated artesunate amodiaquine treatment, and we realized, because of the pharmacokinetics of amodiaquine, the accumulation of drug happens exactly in this window of 1 month. If you have a full treatment with artesunate amodiaquine at one point, and then I have another one in 2 months' time, they will not accumulate. But if it's inside 30 days, they will progressively accumulate levels of this ethylamodiaquine, the metabolite, in the body. And is exactly how seasonal malaria chemotherapy happens every month. So they keep accumulating it. So we have all this information, and now taking in consideration the wonderful large experiment made here in Spain, how can we transform this in something that actually can improve compliance and directly, in fact, save lives? Well, the first issue is that Africa is large. Well, South America is too, but these countries are large and not sometimes very populated, and Mali is a good example. I worked in, I'm trying to coordinate the 2 computers. I've worked here in the southern Mali, where malaria has its biggest incidence, and you can see there that the distances are brutal. Between these cities is 300 kilometers of roads that are what they are, and especially when you want to go to the small villages. So making any kind of an implementation of pharmacogenetics is particularly, challenging. But there's one good thing in Africa. one thing which was very spectacular, and I have witnessed it during the last years, mobile phones, they are everywhere, absolutely everywhere. In this moment, in 2026, there are about 650 million mobile phones circulating in Africa. And the coverage of internet is getting better, have to be said, because of Starlink. So suddenly, what seems to be enormous distances and very inaccessible places, they might be. Because you can, if you concentrate your efforts in something like e-prescription and electronic medical records that can be connected centrally, you have access, as people will have access of these kind of interventions. But the next thing is that how do we intervene? How do we genotype in the middle of nowhere? And that's where our own experience in malaria comes in. A long time ago, I've been always interested in somehow to genotype the infection, the malaria parasite, because of drug resistance markers that we have been studying for a long time. But, the genome of the parasite is quite small. It's 23 megabases, is 100 times smaller than ours. So it's not completely easy to make the genotyping. We, in collaboration with the company, they have mainly developed a system that actually works like that. It's a system which is portable, which is very inexpensive, is based on real-time PCR. And above everything, which I think is remarkable, all the reagents of real-time PCR, of qPCR at room temperature capacity for 1 to 2 years. So this is a system that costs about, I think that machine costs about 3,000 to 4,000 euro. And the objective is for each SNP to be genotyped for, in the end of the day, for €1. We are on a 2-3 year in principle. All these has been calculations made for the falciparum, for the pathogen. But going from the pathogen to the pharmacogenetics is relatively easy because we are talking about way more DNA with the humans. So here we are. We have this little toy that, is under development that can make a genotyping in 30 minutes for a relatively low price. Because the objective was always focused on the developing world. We also have a CYP2C8 allele that is not that bad in terms of previewing the adverse events of a person. It's about specificity of 0.70 in our hands and an accuracy of 0.63, taking into consideration the phenotypes we're talking about and the regions that we're talking about. So what is the idea in the end? Or in the future, at least? There are 55 million children in Africa under the SMC system, which means that they have potentially about 18 million adverse events per year that will affect the operation, definitely. It would create a lack of compliance and has such, death, in fact, in more cases. So if we take in consideration the data we have, if we can identify the CYP2C8 STAR2 carriers, and we use a different drug, introducing the idea of a second liner in terms of chemoprevention of malaria, it will be possible, in principle, this is just projecting, to avoid about 8 million cases of adverse events per year. If that happens, if we look at both the population with wild type and the population that carries the minor alleles, we can, with this technology, theoretically, with full coverage, decrease to near half the number of adverse events. And this would have, I think, a massive effect in terms of implementation of SMC above everything, because this is enormously important when we do this kind of very large drug implementations, is that this kind of strategies not only directly save lives and create better treatments, but creates a better trust between the health providers and the patients on the other side. And we know that medical products sometimes are not easy to, completely implement. Take the example of the vaccines and the vaccine denialing and all that. So I think that this kind of technology that has been implemented here with the right tools, with the right organization, based on internet accessibility and systems that can actually, for very low cost genotype in the field at point of care, can make a very large difference in Africa. And with that, I thank you all.
Okay, so we will now close the session and thank all the speakers for their wonderful talks. We are running late, so we won't have time for questions, but we advise everyone to contact each other with any questions that you might have. And I also would like to thank personally, in the name of the Faculty of Medicine of Porto, for the invitation to be here in the RIBEF meeting. This is our first time, and I hope many others will come after. And thank you all for your attention, and see you soon.